So we move on to IOSG session. I discussed about the treatment and the challenges, and it's really my proud privilege to have Aniruddha Agarwal. Aniruddha is one of the youngest members of International Uveitis Study Group, and he's traveled all the way from Abu Dhabi. He's working in Cleveland Clinic, Abu Dhabi right now. So Aniruddha is going to talk about local therapy in uveitis, when and how.
Very good evening, everyone. Thank you very much to Vishali ma'am for this kind opportunity, and thank you AIOS. So I will be talking about local therapies in uveitis, when and how, and often it becomes very important for all of us managing patients with even systemic steroids, immunosuppression, to probably add on local agents, and it becomes very important for us to understand exactly what are the indications, techniques and outcomes. We all know the hallmark of uveitis is inflammation of the posterior segment, especially that's what mostly concerns us all, because these patients can often develop inflammatory cystoid macular edema. Apart from that, they can have other manifestations, which we all have seen beautiful photographs from the previous talks. There could be vitritis, choroidal thickening and other inflammatory manifestations. Now, two important entities that can happen are retinal vasculitis and neovascularization. We all know the issues with systemic steroids, because many patients, they require extended treatments with systemic steroids and immunosuppression, which all of which increase the risks of complications such as reactivation of TB and other adverse effects such as derangement of metabolic profile, secondary infections and abnormal blood counts. It's our goal always to preserve vision in patients of uveitis by decreasing the level of vitritis, and also it's the cystoid macular edema. Of course, all the established guidelines talk about early treatment, and our goal eventually in patients who have chronic disease is to reduce corticosteroids to at least less than 10 milligram per day. So with adjunctive therapy, especially intravitreal and local therapies, we can actually reduce the long-term need for steroids. Now, before I tell you when to use local steroids, it's very important for us to understand when not to use steroids. Or any other local therapy for that matter. So we've had some case examples where Dr. Vishali ma'am beautifully showed us that if you do not know the diagnosis, do not inject, whether you're injecting in the intravitreal or in the periocular space. Now, for infections, very much beware. Rule out all infections before injecting steroids or any immunosuppressives. Of course, if it is an infection due to toxo and you want to go ahead with Clinda and Dexa, it's fine. But no Ozurdex or long-acting steroids in such cases till your diagnosis is clear. Now, as a general rule, if your media is not clear, if you cannot see the entire fundus, so if there is a severe vitritis or a cataract, do not inject unless you see the complete retina, because you may have a patient of a chronic uveitis, but there is a concomitant acute retinal necrosis sitting somewhere in the corner. So you don't want to miss that. Also in patients with exudative detachments, choroidal detachments, low IOP, the reason is not known, or if there is of course any ocular contraindication, we generally do not inject. And when can you do local therapies? And I'll show you some case examples. You can do local therapies in patients where you want to use local as an adjunct to your systemic treatment, and this could be for the treatment of choroiditis, cystoid macular edema, retinal vasculitis and panuveitis, or if there is a suboptimal response to systemic treatment, or if there are contraindications and certain specific conditions such as lymphoma, or if you have a patient of immune recovery uveitis where you can potentially use local or intravitreal therapies. Now, of course, neovascularization requires anti-VEGF, and certain infections like viral retinitis requires sometimes adjunctive ganciclovir, but I will not be discussing those two aspects. So most commonly, the agents that we use intravitreally are methotrexate and Ozurdex. Of course, now sirolimus is available. We have adalimumab, infliximab, and also fluocinolone implant, which has been recently FDA approved. Anti-VEGF and antibiotics are available, and Dr. Manisha ma'am is currently, I think, doing a study on the intravitreal use of anti-TB medication. So there are lots of drugs in the pipeline, really, but methotrexate and Ozurdex are the most important ones. Now, methotrexate initially was used for lymphoma, but now the indications of use of intravitreal methotrexate have expanded. It's a very useful adjunct, has no side effects such as rise in IOP or cataract. Of course, it can cause corneal epitheliopathy, but usually there is no retinal or choroidal toxicity. So there are a number of studies which have used methotrexate intravitreally as an adjunct. And looking at this patient here, now this is a child who came with macular choroiditis lesions. Now some of these patients I had the privilege of learning from Dr. Vishali when I was in PGI and managing them with her. So this is a young girl who had 636 vision. The MON2 was negative, quantiferon negative, and the CT scan was negative. So you can see this patient, of course, she received oral corticosteroids, and because the lesions were macular and we were reasonably very sure that this is no infection, this is definitely not syphilis like the ones showed us or toxoplasmosis, so we treated with a concomitant intravitreal methotrexate. And you can see here that the OCT angiography shows you the characteristic hyporeflectivity, the autofluorescence shows you hyperautofluorescence in the center. And so along with intravitreal methotrexate, this patient did very well. And at 6 weeks, you can see the autofluorescence is completely clear. And what impressed me most was that the RP was completely intact on autofluorescence. And the OCT again, it shows you complete normalization of all the layers. The OCT angiography, of course, always shows you something, and at 6 weeks it shows you there is some disturbance in choriocapillaries, but of course we may not give it so much significance. The patient is happy and the disease is healed. So the ultimate word is that methotrexate works great. The only problem with methotrexate that we have is it works for a short time. So intravitreal Ozurdex is one agent that could be used longer. And CME becomes an important indication for Ozurdex. So if you have a patient of, let's say, intermediate uveitis with cystoid macular edema, or if it's a posterior uveitis which is non-infective, you can go ahead with the Ozurdex implant. And we've done a study as well in which we analyzed the use of Ozurdex in TB uveitis as well. So we realized that the vitritis and cystoid macular edema and the leakage on fluorescein associated with intermediate, all of this can be taken care of by an Ozurdex implant. So of course we prefer it in unilateral disease, but if it is a bilateral disease, let's say one eye is worse, you can add an adjunct of an Ozurdex along with systemic treatment. There are some patients of choroiditis. Now this is not a classical example, but you will find some patients who, despite systemic corticosteroids, have some amount of hyperautofluorescence on their autofluorescence imaging. And this is probably a residual disease which does not take care of by corticosteroids alone. Usually in our clinical practice, we rarely like to go beyond 60 milligram per day of prednisolone. Beyond 60 milligrams, studies have shown that it's not safe. So going up to 70, 80, especially in heavy patients, is not the preferred practice. So in such patients, you can go ahead with the Ozurdex implant. But please make sure you're dealing with only and only choroiditis and not an infection. So this was a publication of the use in TB uveitis. And of course, this is the blown up ICG image where you can look at the choriocapillaries hyporeflectivity or loss of choriocapillaries in patients of choroiditis. And if you are treating with an adjunct corticosteroid, we realize that if you keep the area of flow deficit less than 0.1 millimeter, these patients, they have minimum disturbance in the flow void areas. So like this patient, for example, this patient healed very well over a period of 6 weeks. And in fact, we did a pilot clinical trial of using corticosteroid systemic along with an adjunct Ozurdex and systemic steroids alone. And we realized that the pattern of healing on OCT angiography and visual acuity are much better if you can add an Ozurdex at baseline. So this is the comparison at the flow deficit area on OCT angiography. And the patients who are in arm with the intravitreal Ozurdex, they did much better. Now I'd like to show you this one patient. This is an Indian girl who came to me in Abu Dhabi with multifocal choroiditis. This patient was heavy, had other systemic issues. And again, like I said, I did not start the patient on more than 60 milligrams corticosteroids. And you see the autofluorescence in the left eye was particularly concerning because you have lesions which are very close to the center. So of course this patient was started on steroids, and in addition I counseled her for oral the intravitreal Ozurdex, and at the same time I rapidly tapered the oral corticosteroids. So it was like 10 milligrams every 3 days after the injection. And within 2 weeks, I found that some of the lesions, especially if you see this near the superior arcade, have actually gone away. So if you see this particular lesion is not even there at 2 weeks follow-up. And this is at 4 weeks. Now at 4 weeks, this patient is completely off oral corticosteroids and almost everything has healed. And of course, the Ozurdex is still going to act. So Ozurdex works very well in choriocapillaritis, especially if you have a sort of a multifocal choroiditis, even placoid, TB. It works very well with reasonable adverse events that we all expect. But remember to rule out infection. This is one Somalian patient who came to me just 2 weeks ago, and she was diagnosed with scleritis and exudative retinal detachment. She was given corticosteroids. Because there was no improvement, someone injected Ozurdex, and now there's a scleral melt in the area of scleritis. And this patient actually had a Pseudomonas aeruginosa endophthalmitis. So if you're not sure, there can be catastrophic complications with Ozurdex. I'll just take 1 minute more. This is an agent. Of course, we always compare triamcinolone with Ozurdex. And the POINT trial was recently conducted, which showed that intravitreal triamcinolone works as well as Ozurdex. Of course, the duration of action is less. But personally, triamcinolone, I do not prefer in my practice because of the higher chances of glaucoma and cataract. It's very useful for cystoid macular edema in intermediate uveitis. The MUST trial also talked about fluocinolone implant. Now, the Iluvien has been recently FDA approved for non-infectious uveitis, but I do not have an happy experience because 1, it's not as effective as Ozurdex, and 2, it does not last really very long. It doesn't last more than 9 to 12 months. Like the company claims it's 36 months. I think that's not true. Intravitreal infliximab has been used. Now, it has been used since 2010. It's not new. Systemically, it works great. It's FDA approved. But there are significant concerns with regards to retinal toxicity. So there are a number of immunogenic and retinotoxic effects with intravitreal infliximab. In fact, in 2021, this study was in patients of Behçet's, where they showed that intravitreal infliximab was associated with a high complication rate. So it should not be a substitute for systemic infliximab or biological agents. So methotrexate, sirolimus, we have a number of agents. Sirolimus, of course, is not so much marketed in India, not so much preferred. The efficacy is much less. Intravitreal adalimumab is an option which is coming up. There are very few studies, however, to support its use. But of course, we have methotrexate and Ozurdex, and if these agents are used judiciously, they can work wonders. So thank you very much, and I'll be happy to take any questions.
Thank you very much, Aniruddha, for opening up an entirely new area of treating non-infectious uveitis with local injections. So any questions from the house? I have a question for you. Like, one girl you showed was methotrexate you treated, and you said it's a short-acting one.
Yes.
So if required, what would be your limit for giving local injections?
Methotrexate, even Mark Desmet's paper, if you see, where he is used in methotrexate in TB uveitis, usually if it's a macular lesion, we give 1 injection. If necessary, we repeat at 2 weeks. But usually the mean number of injections is not more than 2 or 3 maximum. So if you need more, then of course prefer a longer agent like Ozurdex. But otherwise, not more than 2 is usually necessary.
Okay. Yes, Mudit, please. There's a mic.
The other point, advantage of methotrexate is also it's a very safe drug. So even if you're giving it intravitreally, like what our experience has been with lymphomas, people have given multiple number of injections. The initial induction dose actually is like 2 injections every week for 4 weeks. Yeah. Then you go on for a consolidation and a maintenance. So for lymphoma patients, end up getting 10, 12, 15, even 16 injections of methotrexate without a problem. So that is probably another advantage of methotrexate, that it's a very safe drug.
And very cheap.
And very cheap, yeah.
It's very cheap.
Yeah, one thing I'd just like to add, like if you have we had a patient, ma'am would remember, of viral uveitis, and these patients sometimes, once the virus is healed, they can develop CME, which is non-resolving, and they may benefit with intravitreal methotrexate without the risk of really reactivation of the virus.
Yeah, exactly.
I have got a patient of intermediate uveitis who had depression and as well as the glaucoma. So only option I had that give intravitreal methotrexate, and she is quite happy. She wanted the injection in other eye also. So he gave that injection.